You're listening to RX Inspirations, our new show where we highlight people across the wild world of pharmacy, making a difference in their communities. I'm your host, Mason Manuel, and I'm coming to you from the home of pharmacy at the American Pharmacists Association, APHA, here in Washington, D.C. I'm joined today by Randy McDonough, president of APHA and all-around superstar, who will be leading our conversation today. We are also joined by Dr. Ashley Moose. She's a pharmacy owner, director of network development, and CPESN. Now we're going to learn more about all the magic that she makes, so Randy, take us away.
Before we get started with having an interview with Ashley Moose, I wanted to explain to everyone, why we started RX Inspirations, which is an APHA webinar series. Throughout my career, I've been inspired by pharmacy practitioners in the trenches. It's those individuals in practice who are providing exceptional care to their patients daily, even faced with tremendous challenges. My goal with RX Inspiration is to highlight pharmacists, technicians, and practice partners who are making a difference within their communities to ensure that their patients' medication and health needs are being met. Perhaps these individuals started a unique service. Maybe it was partnering with other providers or community organizations, or perhaps it was just an extraordinary action performed by the pharmacy practitioner during their usual workday. Each individual, each interview, each story will hopefully inspire all of us to practice to the top of our training, challenge the status quo, and help lead us to create our own destiny. And with that, I'd like to introduce Ashley Moose. And Ashley, I was wondering if you could give a little bit more about your role with your being an owner and also with CPSN USA.
Absolutely. Thanks, Randy. And thanks for having me on the podcast today. It's always exciting to share about our practices and collaborate and try to make each other's practices better. And that's why we're here today. So yeah, This pharmacy location was opened in 2020. And you all know what happened in 2020 when the world completely changed. And we opened in January of 2020, shut our doors and did curbside only 2 months after that. So it was an interesting startup for a pharmacy, but our pharmacy quickly became a hub for point of care testing, for immunization delivery, as many of our community pharmacy sites were. And since then, we've been really trying to incorporate a variety of different services in to mimic a health hub site within our community. That's just more than dispensing of prescriptions. Of course, that's what we do. That's what brings customers into the doors. But we also try to provide customized adherence packaging. Of course, our immunizations. We participate in a number of value-based contracts, working with different payers to figure out social determinants of health, barriers to care, improving quality of life. And then most recently, we've implemented a direct primary care primary clinic within our pharmacy. That is about 1.5 to 2 years in implementation now and seems to be going well. So lots of fun projects that's going on every day. We step out of the bed and there's always something that's creative, that's hard work, that challenges you to get moving and to figure out something and figure out how we can be a better community pharmacy in our community.
Appreciate that, Ashley. Thank you. You use the term health hub, and to tell me more about that, why you made that decision to become, and especially now you got direct primary care within your practice as well. Yeah. And within your community, do you have other providers? And if so, how do they feel about what you're doing? But if you could expand upon that.
Yeah, it sort of happened organically, Randy, particularly over the few years that COVID dramatically impacted our practice. We had patients walking in the door for needs that couldn't be met other places. The ER was spilling over and there was 3-hour waits, if they're that lucky. Urgent cares were popping up all around our community. Our primary care they're kind of maxed out in our community where patients have to drive, closer to Charlotte for care, for basic primary care needs. So that really changed the way we try to accommodate patients that had needs. And that's why I believe point of care was so successful within this site too, is because, if there was some type of symptoms they were experiencing, they needed answers now so that they didn't expose family members or other coworkers. And customers began to realize that this was a site where they could find answers quickly and affordably. And that just drove other services that we're trying to perfect even now in the payment model. So, I think our local community of providers are glad that this is an option that they know their patients are taken care of. And we stay in close communication with them as much as we can to let them know the care that's being provided. But we're not replacing what they're doing. We're a supplement to what they're doing. I think it's really helping. It's really helping folks because they have a solution, or they have a place where they can get answers without a 2 to 4 week wait to get in to see primary care, or having to spend a lot of money through an urgent care type of practice.
You kind of briefly touched upon value-based contracts and getting paid for services. Now you got this direct primary care happening as well too. What are the challenges that you're running into being a community pharmacy? Because you talked about it's still about dispensing medications because that brings the patients in, but that may not be enough. Can you explain what's going on within community pharmacy practice and why you've shifted into some of these other services?
Gosh, yeah. So there's challenges on every end of that, right? So we tell our staff, take care of the customer that's in front of you, take care of them as efficiently as possible. But also don't forget to focus on, we're moving to the services side. We want to untangle ourselves from these buy-sell types of arrangements that our community pharmacy model has gotten us into. We have to be able to provide services and to be here in our, to be relevant and an important piece of our community as a community pharmacy. So the challenge that we face right now is, how do we flip the script with even our staff buy-in of, we need you to focus on these services, but we also need you to take care of the patient and their medications as quickly and as accurately as absolute possible. And that's the challenge, and that's the balance that we're facing. Now, we're getting better. I wouldn't say we're great at it, but we're getting better at figuring out the balance of automating certain services, using our technology a little bit better to make a systematic process to our different value-based contracts so that opportunities aren't lost. We have to train more than one person in the pharmacy to know how to do these different types of activities, how to engage customers in ways that they don't feel like, particularly with like health risk assessments. Every time they come in, we don't want to ask them 12 questions about personal matters. So how do we build the relationship so that they understand, in this healthcare hub model, we're here to make impactful interventions that at the end of the day helps them be healthy and have a high quality of life. So I would say that's our big challenge, is to maintain our staff focus on what's important at that given moment and catching those balls that are going up in the air all at once.
I appreciate that. I can remember being challenged once by a colleague of mine that's more involved in the research side of academia. And he challenged me, saying, the things that you're really professing out there and the things that you're trying to transform, he goes, this is not rocket science. And I said, you're right, it isn't rocket science. I said, but let's do an analogy. And I said, in this particular situation, this scientist was involved more in pharmaceutics. And so I said, let's just say the dean comes to you one day and they say, hey, we got something we got you to do. We got to move you into medicinal chemistry because pharmaceutics funding is drying up, and we see that there's going to be more funding in the future for medicinal chemistry. But here's the catch. You still need to do the current research as you move into this new research. He goes, well, that's impossible. I said, that's what we're asking community pharmacists to do right now. is a whole different business model, a whole new way of practicing. And you do have to balance because we still have to be the efficiencies of a dispensing model while providing good, exceptional care on the patient care side. I'm excited that you talked about value-based contracting because you've used that term multiple times. I'm sure people want to know, are you actually getting paid? And what are the different payment models you're involved in?
Oh, Randy. So, it's so funny that, we're talking about those challenges, right? Because for years we've said we need to pay pharmacists different. We have to figure out a different payment model. And there was one moment, I think, as the end of the year, we were getting so, I don't want to sound ungrateful for this because this is not at all. We were getting several payment contracts and I just couldn't get to them all. And I was like, this is what we've been praying for all of these years, is that we have all these, and now it's here and we've got to scramble to figure out how to efficiently manage all these value-based payer contracts. And we're not, we've got room to grow. We've got lots of opportunities still. And we think that we're still being underutilized in community pharmacy for the value that we could bring a lot of payers, whether that's, ACOs or MCOs or, commercial payers. There's so much value that we could bring, but we do need to engineer our practices and get really good at that side too. So you're right. There's that engineering that has to take place to do both critical points of care for our patients. So we're involved in a variety of different services, whether that's from the MTM side of making sure patients have a thorough medication reviews from different payers to simply making sure patients are adherent to their medications through our adherence programs, health risk assessments, allowing for more of I don't want to say a care management approach, but figuring out where the pain points are for patients and to be able to optimize their health. Are they having difficulty affording medications? What can we work out with them from a community pharmacy side? Are they picking between their medications or their electric bill one month? And what resources in the community are available for that? Is there mobility problems? All of these things can come out when you simply start to build the relationships and ask, what is it from your standpoint as a patient from being able to control your chronic disease? And there's a lot of non-medical factors that play into that, as we all know.
I appreciate that. You mentioned about social determinants of health. And so the question I have for you, because I know from your own practice that you have not only optimized the pharmacist license and training, but you also optimize your other staff. Can you talk about how you have changed the role of maybe your technicians and perhaps your delivery drivers as well?
Yeah, absolutely. You hire different. We're now hiring technicians that have a medical background. Maybe you've worked in a clinic or have people skills. Sometimes that's the most important thing. Maybe they haven't had a lot of medical background, but they are sweet, caring, compassionate people that want to solve a problem and want to feel good at the end of the day for helping someone achieve something that they couldn't have done without them on board. So I think it changes the type of individual you're looking for to bring onto your team. But we're expanding those, we have roles specifically now for someone who conducts health risk assessments. We have a sync specialist that's all she does is reach out to individuals all day long to say, how are your medications going? Do you feel, are you up to date on your vaccinations? Where can we help to optimize your medication regimen? And then making sure they're ready on the day that the patient needs it and that there's no gaps between, those steps. And so we hire different roles now. It's not just a technician. It's people with good people skills that care, that not that we didn't hire those people before, but their roles are set to be different. And I wish I could hire 10 more like community health workers. And we're training our staff more and more to take on some of those roles and get mental health training and, when you're in a patient's home, you may deploy, you may be asked to deploy to a patient's home. Are you comfortable doing that? Here are the things that you're going to look for. Here are the things you're going to assess. And then here's where we're going to take that information and feed that back into the medical team so that we can make some type of impact for them. Maybe it's our elderly patients. Maybe there's small things that we can do from a community pharmacy standpoint to keep them happy and healthy at home for a longer period of time.
Appreciate that. As we talk about the different roles, I mean, you've optimized now the engineering, or you're trying to optimize the engineering, right? You're optimizing the role of the pharmacist, and you're also optimizing the role of your support staff. So you've kind of have created a different type of a practice setting. I know we talked a little bit about the challenges, and it's not just the people, it's the reimbursement and everything else. As people start going into these new practice models, let's look at direct primary care. If you could expand upon that,
Yeah.
what is it? What were the challenges to do that? You've been in it for a year and a half, but where do you see the future going with this? So I know that's a lot of questions thrown into one.
It is, but it's really, it's things we think about, we sleep about, we wake up thinking about it. I think it's an important piece of our growth modeling and being, and having a solution in the community. So it's not the only solution. There are lots of ways to create this health hub model, but it is a solution. And it is a solution for folks that need convenient access to a primary care provider. In direct primary care, our model, it doesn't have to be this way, but in direct primary care, our model is cash only. And it's membership based so that you can have an ongoing relationship. If I wake up with pink eye tomorrow morning, I have a relationship with my provider. I can text her. I can show her a photo. She can jump on a video with me. I don't have to take time off work to go into an office and sit half of the day to be assessed for something very simple that can be treated very quickly with the proper assessment and a proper relationship. And so we're trying to create quick access, affordable access, in a way that's convenient for patients that may wish to access that kind of care. It is concierge in some way. There is a model for concierge, and I would say we're some type of blended model of that, where the provider's always accessible through a simple text message, and she's in the office during set hours. But we're fulfilling roles, and it's taken a minute of time to really educate our community that healthcare doesn't have to be complicated. And this is a service that you can use. And once it's caught on really quick. And I would say we've had probably our most growth this year, probably from January to now. We've seen the most. It takes a minute to really get that marketing out there to people know that there is this model that exists, and we hope it'll continue to grow, and we hope that people will continue to utilize it because it is convenient, and it's great for anyone that's uninsured, or maybe you have a really good primary care provider that you want to maintain a relationship with, but sometimes it's just not as easy to access, and there's a backup for that. So I don't think we can be a primary care solution with the provider in place, but we don't have to be the only solution with that. So it's adjunct.
And what kind of provider is this person? Is it a nurse practitioner? Is it a physician? What kind of practitioner?
She's a physician assistant, and she has a collaborative agreement with a physician or MD that oversees. It's very closely aligned. We talk often. She meets with the provider on a regular basis, overviews the charts, that type of arrangement. But it's working out really nicely, and I think people are getting cared for, and that's the goal.
And tell me the role of the pharmacist in this situation. So this person's located within your pharmacy and within your practice. And then so the patient will come to see this individual for some kind of a primary care need. And then what's the role of the pharmacist as it goes beyond that person?
Yeah. So it's a role that's evolving, I would say, because we're getting more comfortable working with one another. And that providers more comfortable working with our staff as well. So now we've got a phlebotomist. This is pretty new on site that's able to do blood draws. Before the provider was taking care of that, but as the model's starting to work out and we're able to kind of hit different financial metrics, it's time to expand because it's getting really hard with this many lives involved. So we've got the phlebotomist that serves dual roles. We've kind of got some shared staffing roles as well, where there's some phone maintenance and patient care details that are handled. The administrative staff, there's some shared roles with that. So it really optimizes kind of the behind the scenes of the clinic operations. But what we're trying to perfect and explore now is, as we have student pharmacists coming into the pharmacy, is there a role for kind of the setup, the blood pressure management, is there any A1Cs that need to be taken? So there's so much more we can do that we haven't really explored yet, but there's appetite to really create this collaborative practice of pharmacy and the education side of this is the diagnosis or this is what this patient is dealing with. Now, let's get the medication experts involved to really optimize what needs to happen so that in this direct primary care model, this patient doesn't have to come in every 2 weeks because their blood glucose is out of line. Call the pharmacy and see if, there's setups that we can work through to make sure the patient has a stable care delivery, and that when there are problems, there's multiple staff members and that can really get things figured out and managed better with chronic diseases. So we're getting better at that, but we've got some work to do, and we're trying to figure out the right workflow for the clinic operations.
Very good. Some very exciting things that you're doing. And, one of the questions I want to make sure I did ask you, because we did mention CPSN. And for those listeners who aren't familiar with this, but could you just describe what CPSN is, your role, and, what's the value of why this was created?
Absolutely. I hope many of the listeners are familiar with CPSN, but just in case you're not, we are a network, a clinically integrated network of providers, of pharmacy providers, and that are located in the community pharmacy setting. And we are, our challenge is to aggregate high-performing, quality community pharmacies who wish to practice in the service-based model. So, yes, we are dispensing. Almost all of the pharmacies that are part of CPSN are dispensing pharmacies, but we're looking to aggregate with other like-minded community pharmacies so that we can go to payers and say, this is the value that we can provide, and we are a network of providers that's ready to go. We can improve patient outcomes. We can lower healthcare costs. I believe wholeheartedly we can do that. And we have research, as Randy's group in Iowa, they have a ton of research showing the positive impacts that their community pharmacies are making on chronic disease state management, on medication management, and total dollars saved with the patient's lives just by the pharmacist intervention and that pharmacy team's intervention. And that's what CPSN is about, is aggregating to be able to express our value in a way that we couldn't otherwise outside of this arrangement, and be able to pitch this to payers that are looking for cost-saving ideas that are innovative but also effective.
I think the key term that you had was clinically integrated network, which allows a group of individuals or pharmacies to contract on behalf of the network, whereas if we weren't a clinically integrated network, which is a legally recognized term, we couldn't do that, right? And so it allows us to be able to do it. So I appreciate your description of that. My last question for you, Ashley, is, for those people who are thinking of, what do I need to do to be able to get to a practice like this? What's a key learning or a key takeaway that you would tell someone about trying to move into a new type of a practice that's more service-based and new reimbursement strategies?
Well, I mean, from the practice level, you have to have buy-in from your team. Yes, you will be involved in it, especially from the get-go, but your team has to understand your why and where you're taking your practice. Without that, it'll collapse. You just, the pharmacist alone simply cannot handle the opportunities that are coming available. It has to be a mindset, a model change, a mission within your community pharmacy to want to provide these types of services. That's one learning. The other learning is, I think we've got to become salesmen. We've got to be good at promoting what we do and the value that we provide. We sit in our walls of our pharmacy, and we know we do these really I think we know that we provide this really great customized service, but we don't tell anybody about it. And a patient may drive past 5 or 6 different pharmacies to get to my pharmacy. Do they think we're all the same? I hope not. I hope they know that we want to be different. We strive to be different. And our entire reason for existing is to provide high quality care so that they leave with a smile on their face, or they leave with a problem resolved that they didn't think they knew how to solve before coming into our pharmacy. That's it. And if we don't do that, then we will not be effective in the marketplace. We might as well shut our doors. And I hope every day that the staff comes in with that mindset too.
I frequently say to my staff, be careful what you ask for, you just might get it. And I think that's exactly what's happening here, where we are having now payers and people saying, hey, okay, we see the value of the community pharmacist, but now you better perform, right? Because that's when the clock starts.
That's right. This is our time. This is our time to really execute on the value-based contracts that we have received. And should we not, we may not have any more, or payers will look for different alternatives. And I believe we're up for the job. And I know many of the community pharmacies, especially within the CPSN network, are too.
Yeah, totally agree. Ashley, I sure appreciate your time today. Thank you for being my first guest on RX Inspirations. And I think you really provided all of our listeners with a lot of good new information about new types of practices. So thank you.
Thanks for having me on. And Randy, great. I wish you the best luck over the next year.